so much for joining us. Many of you have heard my voice before. This is my umpteenth webinar of the day and probably my millionth of the week, so excuse my voice, but I am Beth Samanuk. I am the VP of Sales here for EyeCareLive. I am thrilled to be bringing you a webinar tonight on billing and coding for telemedicine. There is no hotter topic right now, and we get questions around the clock about billing and coding. So EyeCareLive as a company is thrilled to be able to provide you with this resource right now. So many have so many questions. Telemedicine is new to some of you, not new to others, but I think we can all agree we will learn something tonight. Few housekeeping items. If you look at the bottom of your screen, you will see a Q&A button. I'm asking that you put any questions in the Q&A button instead of the chat. The chat tends to get very full with comments, and I don't want to miss anyone's questions. We are planning on taking some time for Q&A at the end of this call, so we will try and get to as many as we possibly can. But without further ado, I'm going to turn it over to Dr. John Rumpakis, who is going to be our leader tonight and handling this webinar. So John, thank you for being here. It's a pleasure.
Beth, thank you, and good evening, everybody. I'd like to take a moment just to thank EyeCareLive for creating this opportunity for us to get together and discuss this. It's unfortunate the circumstances like this have to bring a topic like this to light, and I wish everybody well and hope that everybody is staying safe and staying healthy, and just would encourage you during your course of your day, take care of yourself, your business, and take care of others around you that may be a little less fortunate as well. So that being said, as Beth said, this is very much a timely item. My goal tonight is to be able to help to simplify this topic. It's not as complicated as many are making it out to be. There were some significant changes that CMS made to allow us to be able to do things in a more relaxed fashion. I'll pass those along. I'll point those out as we go through. But coding for telehealth visits is not a complicated thing, and my primary goal tonight is when you go to your practice tomorrow, you're working from home tomorrow, that you can help your patients and really create a win-win across the entire board out of this healthcare chaos that we're in. I'm John Rumpakis. I pretty much spend my life on coding, compliance, and medical economics. I do a lot of work with a lot of different companies. I'm honored to be the reimbursement consultant for EyeCareLive as well and help them with their platform as we do things. I also write for many of the journals, and I do have ownership interests in my own coding software and things like that in the marketplace, none of which will be discussed tonight at all. Everything that I'm going to show you tonight is valid as of this evening. The CMS values that I'm going to show you are national average values for each of the procedure codes that we will be viewing. Remember that policies do differ based upon where you're at. Not so much with Medicare, but your own local carriers and other commercial carriers or Medicare Part C carriers, policies can differ greatly. So please make sure that you take your information that you get this evening, and as you're going to apply it to different carriers, go onto their websites and try to search for telehealth guidelines that they're going to be using. Many have adopted CMS's more relaxed requirements, so that's a very, very good thing. But please don't put yourself in a position of jeopardy as you embark on this with carriers that are other than Medicare. Okay, so let's just kind of start with what telehealth was prior to March 6th of this year. So there are some primary definitions that we always had to have, and one of the more restrictive areas of it was what we called the originating site, and that was defined as the location of where the patient was. So traditionally, the patient had to be in a county outside of a metropolitan statistical area or in a rural health professional shortage area in a rural census tract. So Medicare had a great tool that you could actually go to, and it looks something like this. You could put your street address in it, the city, the state, your zip code, and it would tell you exactly where you were and if you qualified and if the patient qualified for a telehealth visit. The distance site is where the provider normally was. Now, typically the provider was in their office or at a different location, but the patient themselves had to generally travel and be in an area where telehealth visits were required. The qualified providers are physicians. So obviously with optometry being a physician under Medicare's guidelines since April 1st of 1987, we qualify, but also other types of federally qualified healthcare workers are allowed to provide telehealth visits as well. So telehealth services in general are office visits, psychotherapy, consultations, which they just added recently, and other types of medical or health services. So the two that we're going to focus on this evening are really the office visit side of telehealth and the consultation side of telehealth. When we look at communication services, there are two types, synchronous communication and asynchronous communication. So primarily telehealth is based upon the definition of synchronous communications. That means a two-way live interaction between a patient and a care provider. So typically that had to be under a given platform, something like eyecarelive, where they had a specific platform that accessed the video and audio aspects of your device that you could communicate through. We'll see some changes in that as far as what kind of devices that we can now use, but that's what a platform generally had to deliver, was synchronous communication services. Only in a couple of states, Hawaii and Alaska, were asynchronous communication services allowed. That means that the patient could have done something ahead of time, it was stored, and then it was forwarded to the physician themselves that they could now look at that information, not live and in real time two-way. So those are the two types of communication platforms that existed. So traditionally, telehealth services were only covered by Medicare if the patient was at a remote doctor's office, they were at a hospital, at a critical access hospital, rural health clinic, federally qualified healthcare facility. You can see here that it was very, very restrictive as to where the patient could be being at the originating site. And so one of the things that has changed is how Medicare has now approached this. So under a recent alert, right, the Coronavirus Response Supplemental Appropriations Act and a Section 1135 waiver, it broadened access to telehealth services so any patient can get a wider range of services from their doctors and other clinicians without having to travel. So essentially, it allowed this to be able to be delivered at the patient's home. So the patient did not have to travel anywhere else and be able to still maintain that social distancing that's there. So when did it happen? The original legislation was on March 6th of 2020. It provided the Department of Health and Human Services with the authority to remove these restrictions. And then on March 17th, Medicare took action to relax the telehealth rules under an 1135 waiver for the duration of the COVID-19 health emergency and made everything that they did retroactive to March 6th. Additionally, and another big thing because of the economic hardship that's going on right now, is Health and Human Services Office of Inspector General, the OIG, is providing flexibility for us as healthcare providers to be able to waive or reduce cost-sharing aspect of it to patients. So typically, a patient always had a copay or a deductible that they had to meet. Those are being, they're giving us the ability to waive those without penalty during this emergency time period. So prior to this announcement, again, Medicare could only pay for telehealth services such as routine visits in very specific circumstances. Now it's really broadened it quite a bit, and it's allowed the beneficiary to get telehealth services while they're staying in their home, and you could be in your home. Again, they can get it in any healthcare facility, so this really allows us to offer it on a broad basis. Okay, so now let's talk about some things that haven't changed. We have to understand coding. we have to understand coverage, and we have to understand reimbursement. Now remember, all three of those things are different, right? Coding is how we accurately and legally describe what occurs during the patient-physician encounter, whether it's virtual or in person, right? It's how we describe what we do. Coverage determines now how carriers will either help pay for this and or set policies in order for us to pay. So we've kind of talked about the relaxing of the policies that's taken place, and now how the carriers have really broadened that, so that way we have much greater latitude in what we're doing. And then reimbursement obviously is how much we're able to get paid for the delivering of these things. Why do I mention these three? Because they're all different, right? How we code is one thing. How we get paid is another, by carrier policy, and then how much we get paid is determined by your carrier agreement that you have with your carrier. These all come under an umbrella of legally required compliance. So why do I say those things? So all encounters really have a beginning and an end. A traditional encounter, right? A patient presents to your office. Your staff may triage that patient, determine what kind of resources in your office was necessary, and you as a physician had to determine, right, type of examination, level of exam, and other tests that you were going to do, and that was a successful encounter. Telehealth isn't too different, right? Many of the codes require that the patient initiates the encounter. You're now going to determine what you can and cannot do during the course of the overall visit, right? You're going to have to determine what type of examination, what type of level of examination, and obviously then not tests to be ordered, but what's the additional steps that that patient is going to take, and what's going to happen within the previous time period and the time period after your telehealth encounter. So very similar process in what we do. So other things that haven't changed, right? We still have the ability to make sure our requirement, that the medical record is absolutely pristine. So in fact, in many cases, your telehealth requirements are even more strict in many cases, because they require time requirements. You have to document what time it starts, what time it ends. And so we have to remember that we cannot fraudulently or misuse codes just to get paid for something. We actually have to code things properly. We have to follow the rules with those codes with good intentions, right? And all of these things mean that we have to do these things in respect to our agreement with our provider agreement that we have with our payers, right? Remember, your contract, your payer agreement doesn't change at all. Those rules of recording in the medical record have not been relaxed at all. All we've done is relaxed access and made access much, much easier for everybody. So accurate coding and billing, accurate medical records documentation are essential. You can only bill for what you're actually doing and what the code actually requires that you do, okay? So be very cognizant of that when we go through the codes. Make sure that everything's accurate, written down, and that you're doing things appropriately, particularly for the post-telehealth encounter, okay? And remember, you're still submitting everything on a CMS 1500 form, so you're certifying that everything's true, you're familiar with everything, you know all the rules, you allow Medicare to come in, and you're agreeing to be prosecuted under federal laws if you violate these rules, okay? So now, one of the things I'm going to talk about, because I'm not in sales, unlike Beth, right? So I am a reimbursement consultant to eyecarelive. So people ask me all the time, John, do I need something like eyecarelive to do telehealth? My answer is you don't need a specific platform. However, how specific platforms are organized makes it significantly easier to be compliant with everything that's required to go into the medical record. So a platform like eyecarelive allows you to accurately record everything from the chief complaint through your HPI to your physical examination itself. It allows you to be able to record it properly, and then it can also synchronize in some cases with your EHR. So it makes the entire encounter so much more easy and fluid. The other way you could do it, of course, is you could have a video screen up on your record and your EHR up on your computer screen side by side, and you could be typing into your EHR as you're doing it. Now, you have to decide what's best for you. I think the platform allows you to be compliant in a much better way. And once you're used to a platform, of course, after this relaxation of rules has gone away, guess what? You're now going to be into a platform that also maintains HIPAA requirements and all of the other things that goes along with the telehealth encounter. So following these rules isn't optional behavior. And we know that today things are changing extremely fast, right? So let's talk about some basics. Just remember that every CPT code is unique. Every CPT code has a specific definition and a set of characteristics and guidelines that determine what you use and how you use it in your clinical practice. So what are the code sets applicable to telehealth? Very first, of course, are the traditional evaluation and management codes, CPT range 99201 through 99215. We have virtual check-in and image review codes, which are HCPCS Level 2 codes, G2012 and G2010. We have the Medicare online digital evaluations, which are CPT range 99421 to 99423. Telephone services, CPT range 99441 to 99443. And then interprofessional consults that go 99446 through 99449, 99451, and 99452. So one of the things I get asked all the time is, what about the ophthalmic codes? 92004, 92014, 002, 92012. Well, those are not allowed. None of the 92,000 codes come under the covered code sets for telehealth encounters. So as much as you might be inclined to say, but John, I use the 92 intermediates all of the time, and why won't those suffice for an anterior segment type of an encounter if a patient is having a problem? They're not approved for telehealth. So you're going to have to revert to one of the code sets that are listed here under the bullets to be able to actually do that. Okay, so moving forward, let's take a look at these. Let's look at the E&M codes. Just a brief review, right? We've got 5 different levels of codes. Remember, the difference between a new patient and an established patient is that patient hasn't been seen by any practitioner of the same specialty and some same subspecialty in the same practice for at least 3 years. So that's the difference between new and established, right? That was modified and updated in 2012. Remember that your code maps, right? 99201 is really equivalent to a 99212, an 02, same as a 13, and so on, okay? So as we go through those, remember that in order to do an E&M visit, you have to have a very specific level of history. You have to have a specific level of physical examination, which we'll get into in a moment, and then your medical decision making. So remember, your history consists of your chief complaint, your various levels of HPI, your personal history, family history, things like that, review of systems that you have to go through. Your physical examination under the E&M codes, right, have 14 specific elements that you're going to do. Now, I've highlighted the ones that are typically going to be done with a telehealth encounter, right? Through a two-way video that you're taking a look at somebody, right? And you have to think of what you're doing. Now, I've had people argue with me, and I don't mean argue in a bad way. I mean, put forth the argument, well, John, I can have the patient do EOMs or motilities because I can guide them through the video two-way on how to do things, and I can observe their eyes while they're following their finger, or I can be doing my finger and they could be watching me on the screen. So we could add theoretically, we could add an arrow to that as well. Some platforms like eyecarelive allow you to take visual acuities through the platform. They have a methodology that allows you to do that. If you're not using a platform, VAs are not something that you can actually do. Obviously, You could look at the adnexa. You can look at the bulbar and palpebral conch. May or may not be able to look at the corneas and may or may not be able to look at the irises, right? Never forget that on your patient's device, they have a light as well. So you have the ability to control illumination on the patient side if that helps you see things additionally, and if you can coax the patient or guide the patient to how you want to position things. But these are typically the things that you're going to be able to observe in a telehealth encounter. So if a patient was a new patient, right, really what we're going to be able to do is probably in the level of a 99201. Maybe a 99202, but I think we would really be pushing that envelope because remember, we have to have at least a minimum of 5 physical elements in order to qualify for a level 1. We have to have at least 6 to 9 to qualify for a level 2. So I'm going to say that, you're pretty much going to be in a 99201 probably most of the time. For an established patient, that's going to move it to a 99212. Now, possibly you could also move to a 99213 because remember that under an established patient requirement, you only have to meet or exceed 2 of those 3 areas. So history and exam, history and decision-making, right, or exam and decision-making that you would do. But again, most of the times I think it's going to be a lower level visit. Not too bad though. So if I looked at what those pay, Medicare pays, $46.27 for a 99201 and $45.60 for a 99212. All right. So not too bad for being able to do an encounter via your platform or your device to aid your patient. So now let's move into the virtual check-in services that we have. First, we'll start with the G2010. Pays currently $12.27 nationwide average. Now, this has to be an established patient. You cannot use this code with a new patient. So it's a remote evaluation of a recorded and or image submitted by an established patient, store and forward, like we talked about earlier, including interpretation with a follow-up with the patient within 24 business hours. This evaluation cannot originate from a related E&M service provided within the previous 7 days, nor can it lead to another evaluation and management service or procedure within the next 24 hours or soonest available urgent or emergency appointment in your office. So this is an established patient who may want to, reach out to you and say, hey, I have this encounter going on and you want to look at, they've taken a picture, they forwarded it to you. You have to get back to them within 24 hours. It's not related to anything that you've seen them with in the last 7 days, and it doesn't lead to an appointment within the next 24 hours or the next urgent appointment that you have. G2012 pays $14.80, and this is now a two-way communication. Again, brief communication, technology-based service by a physician or other qualified healthcare provider who can report evaluation and management services that is provided to an established patient. Again, same rules apply, right? Not originating from a related E&M service provided within the previous 7 days, nor leading to another appointment within the next 24 hours or soonest available appointment. This is really 5 to 10 minutes maximum of time. So really you're just checking in on somebody, right, that you wanted to see what's going on. Perhaps you had prescribed a medication a couple of weeks ago, right, that you wanted to follow up and see how the patient was doing, or the patient was having a side effect of something, or they had a question on something. So this is just checking in virtually with the patient. Pays about $14.80. So those are the two services, the G2010, which is your evaluation of a recorded image or video, and then a live two-way encounter with the patient on the G2012, right? Pretty much in the same ballpark, $12.27, $14.80. So again, summary, provided only to established patients, provided in lieu of an office visit, at least on an annual basis, The patient must verbally consent to these services, and this consent must be documented in your medical record. Again, another benefit of a platform like eyecarelive. These are the consent is documented before you can provide the service, and typically Medicare coinsurance and deductibles apply to these services as well. Now remember, you have the ability during this emergency to be able to waive those if there's hardship with your patient overall. So please keep that in mind. Online digital evaluations. Beth, do you want me to take, I see some questions popping up. Do you want me to take some of these questions now?
Yeah,
Would it be more pertinent?
Yeah, I think, we've got like all of a sudden there is a ton. So I'll start with some, let's see, there are a few about malpractice, like how that plays into telemedicine. Do you have any comments on that?
Your malpractice insurance is your malpractice insurance. So you, again, have to do the best that you possibly can. Again, all of the rules for medical record documentation, malpractice, there's not relaxation of those types of things. So if you need to do a particular encounter or you don't feel like you're doing, you've got some issues with that, then you probably need to bring the patient in. And if it's an emergent situation, you may need to bring them in within that 24-hour period, which would then not allow you to bill for that telehealth encounter.
Okay, great. The next one, and this came in right at the top of the hour, so we may have covered pieces of it, but number one, can telemedicine be billed for new patients? And number two, if I see a patient via eyecarelive video on day one, but decide that the patient needs to come into the office the next day on day two, are we able to bill both visits separately?
Yeah. So new patients, you can bill for new patients under the evaluation and management codes. All of the other telehealth codes require that the patient is established. With respect to the eyecarelive recorded video, if the video was recorded, right, then that would be that G2010 that we just talked about right here. And if the patient came in the next day, we would not be able to bill for both encounters. You would only be billing for the office encounter, not for the virtual check-in service.
All right, next question is, are all of the Medicare carriers currently paying for telehealth? What about commercial carriers?
As I said at the top of the hour, each commercial carrier will have its own policies. They may or may not pay for or cover telehealth services, and they may or may not go along with Medicare's new relaxed guidelines.
Okay, next question is, where would I find codes for telehealth for therapy? For example, 97530. They are what we use in my office for neuro-optometric therapy.
I don't believe that those codes are approved for therapy. However, if somebody would like to forward those codes to me, I'll give you a reference here shortly where you can see all of the codes that are approved for telehealth. In fact, if you want to hold on, I'll pull my CPT book and we'll do this live.
That's amazing. I love that you can, while you're looking, can you do two things at once or no?
Yeah, I can do two things at once. Let me just tell everybody what the reference, where it's located in your CPT book. If you want to see all of the codes that are, all of the CPT codes that are allowed to be used with a synchronous communication, they're located in Appendix P, as in Paul, of your CPT book. So what was the CPT code that they gave?
Let me go back.
97 something?
Yep, 97 something. I'm going back here. Oh, I clicked answer live and I think, 97530.
That is not a code that is approved.
Okay.
Okay.
Okay, next question. This one says, I think you said we need 5 exam elements for level 1. If we can't do visual acuity, can we not bill?
No, you need so 1 to 5 elements is what you would need for a level 1 visit. So no less than 1 and no more than 5. If you move to at least 6 elements, then it could be a level 2 visit, but any amount between 1 and 5 would constitute for an appropriate E&M level 1. Just like it would be in your office, right? The coding is no different.
Okay, great. Next question, is telehealth available for contact lens exams?
I don't know what a contact lens exam is. I don't mean to sound flippant on that. Does that mean that a patient who has a medically related problem secondary to contact lens wear, then absolutely it could be. It would be billed just as an E&M code, just as a contact lens, related problem in your office. Not an issue whatsoever.
Okay.
But if it's just a quote unquote contact lens quote unquote, progress check or whatever that may be, then that probably would not meet the requirement of medical necessity and all of the other types of things that go along with the problem.
Okay, so I'm going to just say here, Helen, if that wasn't what you were getting at, if you want to raise your hand, I can unmute you and let you elaborate on that for John. In the meantime, I'm going to move on to the next question. What about billing E&M codes, E&M 99 codes by time instead of the 3 elements?
Generally, in this particular situation, time is not used currently as a methodology to do E&M visits. Okay, it's only in the rare case where you can't examine a physical element that you would do it, or you spend more than 50% of your time counseling the patient. These encounters are pretty short, right? So when in 2021, when the E&M standards change and how we use the E&M codes change to primarily time, that will be a different story. But at this point in time, it's really going to be your 3 areas that you're going to be focusing on.
Okay, thank you, John. Next question.
I was going to say, let me move on so we can cover the rest of this, and then we'll do more questions at the very end, okay?
Okay, sounds great. We'll hold them off.
Great. So online digital evaluations. So these are codes that have been recently established that describe now an online digital evaluation and management service. Again, they are all established patient codes. Now these require monitoring of cumulative time during a 7-day period. Okay. So anytime you're online with the patient, right? You're going back and forth with the patient. You're checking in on them every day, every 3rd day, something like that. During a 7-day period of time, if you've spent cumulative time of 5 to 10 minutes, it would be 99421. If you spent 11 to 20 minutes, 99422. And if you spent 21 or more minutes during the 7-day cumulative time period, it would be a 99423, paying $50.16. Now, this is again why I say you don't have to have a platform, but having a platform like eyecarelive does help you quite a bit because it automatically records or calculates your time that you have. That you've spent. So that way at the end of the 7-day period, you now can look up the cumulative time that you've done. Doesn't matter how many different, you could do it in 1 call, you could do it in 10 calls, right? It's just doing it on the total basis of time that you're doing it. So that's the online digital evaluation. Now again, remember, communication with the patient without an office visit using an online patient portal must be initiated by the patient, right? And it must be established patient. Communication occurs over a 7-day calendar day period of time, not related to any medical visit in the previous 7 days, and does not again lead to a medical visit in the next 24 hours. And your Medicare coinsurance and deductible apply typically, but during this crisis, you have the ability or discretion to waive the copay and the coinsurance, all right? Now, what about this 2-way thing that we're going on? You can see that the requirement here is through an online patient portal, right? Which is what essentially eyecarelive is. During this time period right now, that has been completely waived. And CMS is now allowing practitioners to use any common platform such as Skype and FaceTime. So another big departure from the restrictive rules that we had before. Now you can use FaceTime or you can use Skype. HIPAA enforcement is not going to be enforced during this COVID-19 emergency period. So if you wanted to hop on a call with a patient on Skype or on FaceTime, you can certainly do it. Now remember, that does not eliminate the medical record requirements that you have to write everything down. So if you were to do something like that, you're going to have to go immediately to your EHR and then record start time, stop time, and everything else about that encounter that you're doing, okay? So anyways, just make sure you kind of know that. It's important because, you know, this may not last where you can do it on FaceTime and Skype and you still have the medical recording requirements overall. Now I'll talk briefly about telephone services. Now the very first thing I want to tell you is telephone services are not covered by Medicare, okay? Some commercial carriers may pay for them. I have not seen that personally. Please check with any carrier that you're going to be billing for telephone services to prior to performing the services, so that way you can know whether they cover it or not. Telephone services are specifically non-face-to-face E&M services, so no two-way video communication, just picking up the phone to report episodes of patient care initiated by an established patient. So again, right, very restrictive. Telephone E&M service provided by a physician to an established patient, not originating from a related E&M service provided by the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours. Okay? 5 to 10 minutes, 11 to 20, and 21 to 30 minutes. 99441, 442, 443. These are not cumulative for 7 days. These are how much time did you spend during that single telephone call. All right? Again, these are not covered by Medicare or Medicaid. Policies do differ by commercial carriers, so please verify. Do not ever use a telephone service if the call results in a decision to see the patient within the next 24 hours or the next available visit. Call refers to an E&M service that you have already billed in the past 7 days, okay? And you cannot report any telephone-based service by the same provider for the same problem in the previous 7 days. So these are kind of like a one-time shot, right? Patient calls up, you would do that, and then at least a week would have to go by before you would be able to bill a telephone-based service again. So not covered. That's why I don't have any reimbursements here, because Medicare doesn't provide any reimbursement data for these services overall. Last category are interprofessional consults. So although these do not involve two-way provision of services between you and the patient, if you need help from a specialist, you are able to now bill for your time, and the consultant is allowed to be able to bill for their time as well. So the billing practitioner, right, and then you need to get verbal consent. Cost sharing means that you have to collect co-payments and deductibles. Those are, again, waived during this period, and everything has to be done for the benefit of the patient. So there's basically 6 different codes. So all of these codes are billed by the consulting physician to the patient, right, based upon total amount of time they have spent during that particular area of review and discussion. So this is what the consulting physician does. Each one of these requires a verbal and written report, which is why 99451 is different, and it only pays $37.53, because this doesn't require any communication to the physician that requested the consult except for a written report. On each of these, the professional must call the requesting provider, give them an update and a written report to follow. On 99451, it is just a written report. The professional that requested the consult, 99452, is what I would be billing for me requesting it, up to 30 minutes, $37.53. So these really aren't telehealth so much respect to the patient, but it's interprofessional back and forth if you need a second opinion on something by reaching out to that other individual, forwarding them some information that they can then look at and review, and then either call you back and write a report or just write a report back to you. So a couple of things to finish up, and then we can spend the rest of the call on Q&A. Modifiers to designate telehealth. So the very first thing that came out a long time ago was modifier GT. Typically, Medicare had always required modifier GT, which is defined as service was rendered via interactive audio and video telecommunication systems. This was eliminated in January of 2018, okay? So here's the Medicare Learning Notice that came out, and you can see the date right here, effective January 1st, 2018. This eliminated the requirement to use modifier GT, okay? So typically modifier GT is not the one that we would be using any longer. Instead, we're going to want to go to modifier 95, which specifically says synchronous two-way telemedicine encounter rendered via a real-time interactive audio and video telecommunications system, okay? So it's really currently recommended that you only use modifier 95 when you're putting it on your telehealth code. So in each one of these circumstances, if I was billing telehealth online digital evaluation, I would put the 99,000 code and then modifier 95, okay? So each and every time you're using a telehealth code or a 99,000 code provided via telehealth, please use the modifier 95 on that code. And then, as I said earlier, Appendix P in the CPT book contains all of the CPT codes that can be used with modifier 95. Okay. Place of service codes. So you guys all know traditionally when you're providing a service in your office, it is using designator 11 for your place of service, which stands for your office. When you're providing a telehealth visit of any kind, whether it's a 99,000 code or any of the other specific codes, virtual check-ins, digital online evaluations, any of those other types of things, please use place of service 02. That tells the carrier, in addition to the modifier right here, 95, the two things used together tell the carrier that you provided these in a telehealth environment. Okay? So with that, let's spend some time on questions, Beth.
Okay, good. We've got a lot for you, John. So first of all, people want to know, are you going to be sharing the slides? I know we're sending them a recording, but will you share your slides or make those available for those who are interested?
I would, with the only caveat that I would want to wait for about a week because I know we're also repeating this webinar in a week. So after the second webinar is over, I don't have a problem disseminating the slides in a PDF format.
Okay, perfect. Because we got a lot of questions. There's a lot of info and people want to make sure they get it right.
Yeah, I think the best way to probably do that, just for everybody on the call, I think if I provide the PDF to eyecarelive, yep, after this is done, then eyecarelive can disseminate it rather than 700 of you emailing me and saying, hey, can I have the PDF? So yep,
that's absolutely right. We can get it out. Okay, so we're going to try and roll through these. We have 39 open questions. Guys, we will stay on the line. John, I don't know if you have anything after this, but we'll try and answer all of these or as much as we can. Is that okay?
No, I'm good.
Okay, good. So first one is if a phone call could be billed as a G2012, any diagnosis restriction?
So G2012 is not a telephone call. It's a two-way, communication with the patient. There's no restrictions on diagnosis as far as I'm aware. Not seen anything published on that whatsoever as far as a diagnostic restriction.
And similar, so we have a couple of questions back to back on these G codes. The next one is 5 to 10 minute maximum or minimum for the G2012.
let's go right back to it. So excuse me. Let me just, I'm sorry, I'll share my screen again in 1 second. Apologize.
Okay. And we have a couple of hand raised as well, John. So I'm going to let some folks talk too in a second.
Okay, and let me, for some reason, Beth, let me see if I can go back to sharing my screen.
Okay. Yep, we got you.
Okay. So there's the G codes don't have a time requirement, right? G 2010, the G 2012 has 5 to 10 minutes.
And they want to know, is that a min or a max?
I'd say I would put it as a minimum.
Okay. Next question around G codes, and then we're going to take some raised hands. You discussed that the G2010 and the G2012 cannot be done within 7 days after an E&M. Is there a similar global period for multiple G2010 or G2012, or can multiple be submitted within 7 days of one another?
That's an excellent question. My understanding is that, you're going to be providing this service, and what it's doing is, as long as it's not from a related E&M service provided within the previous 7 days, right? And leading to an E&M service within the next 24 hours, you're good to go on doing those. I haven't seen a limitation on using these multiple times.
All righty. Let's see. Okay, our hand raises went down, so we're going to keep with with me reading you. The next one is, for each of these codes, we can bill Medicare, but do the other payers at this time? I know it's been encouraged to follow Medicare, but has anyone received that payment yet?
So I did do some little bit of homework. I have contacted a good friend of mine at Anthem, and Anthem is adopting policies. They do try to follow CMS guidelines. They do have some specific policies of their own. So again, Anthem, Blue Cross Blue Shield. I know United Healthcare has telehealth policies as well, but I would encourage each and every one of you to please go to their respective websites and see if they have any updates posted on their current policies and coverage provisions. So I know most of the carriers are really scrambling hard to try to make it easy for all of us to still care for our patients while still preserving our health, safety, and welfare. But please go to the individual carriers' websites themselves and see what they're talking about and what their current policies are.
Okay, next is, I'm just going to kind of cut to the chase on this question. Billing is only allowed with direct physician-to-patient contact. Is that correct? So no text.
Yeah, texting is not
technicians.
Texting, text messaging?
No, like billing with doctors versus billing with technicians doing, like it has to be direct physician-to-patient contact.
Yeah, so I'll go back to it does. I mean, you can go to, here's your allowed providers, right? And we don't employ nurse practitioners, physicians assistants, all of these people. So we can't use a tech. These are only the qualified providers that are allowed to provide telehealth services.
All righty. I think you already answered this, but just to clarify, the G2012, can that be two-way over telephone? Is that correct?
It cannot.
Yep. So I thought. Can you file the G2010 and the G2012 on the same day, same patient?
That's a good question. I'm gonna if that individual wants to forward that question or you get their contact information, I can look that up in my software. Well, if you can hang tight for 1 second, go to the next question, Beth, and I'll look that up here in just a moment.
I'm going to take the name just in case. I know it was Michael Haynes. Michael, no. I'm getting your info here.
Yeah, and I'm going to look it up in CodeSafe Plus here in just a second, okay?
Okay. The next question is, how many days after telemedicine do we need to wait to bill subsequent telemedicine encounters for the same patient, same diagnosis, and in parentheses, follow-up?
I'm not sure I understand. So the depends on the code that you're using. So there's no limit to the 99,000 codes as far as frequency goes, right? But when we're dealing with the codes for the when we're going with the codes for the digital online evaluations, remember those are cumulative time periods that you're spending over a week, right? So if I'm doing these, remember these are how much time am I spending during an entire 7 days?
Do you want me to add? Yeah, let's see. That was from Christina Katz. Christina, if you want to raise your hand if that wasn't answered. And then I've got a couple of hands raised as well. First is Dr. Richard Hom, my good friend Richard. I'm going to allow you to talk if you want to unmute your mic, Richard.
Yeah, I just wanted to follow up on what the fees associated with telemedicine. Anthem has its own telemedicine platform, and they are using a flat fee, non-medical type thing. It's a flat fee that is not coded or anything, and so it's to encourage doctors to do things like refill prescriptions and things of that sort. Anything to prevent that. So in this interim, if you use the platform that they do, then that particular limitation is done. Now, I'm going to try to apply this if I was going to use another platform in this particular period. So I'm actually trying to relax the standards so that it facilitates the provider and the patient working. Number two is that there is no limit in diagnosis because we're trying to encourage refill of prescriptions. So if someone wants a glaucoma medication, yeah, they can fill any type of antibiotic. So we're actually trying to encourage doctors to use their fullest scope of what telehealth is in regards to facilitating patient care. Thank you.
Richard, thank you for your participation. I really appreciate that and for the clarification. Beth, I have an answer for that individual on can the G2010 and the G2012 be performed on the same date of service? Okay. And the answer is yes, they can.
Great. Thank you so much. And I have Christina Katz who asked the question about how many days after telemedicine do we need to wait to bill the subsequent telemedicine encounter for same patient, same diagnosis? Christina, if you want to unmute your line, I've allowed you to talk.
Yeah, so I just wanted to clarify, if I'm doing a 99212, I don't have to wait 7 days for my next 99212 follow-up. I can do that within like 3-4 days. It's just most of the 99 codes I was concerned about.
Yes, so I want you to think about it this way. A 99,000 code provided over a telehealth platform and a 99,000 code performed in your office are exactly the same. They have exactly the same requirements. So you could do that. You could see that patient each day if you needed to with a 99. They don't have that time requirement that the specific digital evaluation codes or the other codes have.
Okay. And then on that same token, I don't have to wait 7 days for my 99212 telehealth if I saw them less than 7 days prior in office. Is that correct?
That's correct as well.
Okay. Thank you so much.
Yeah, you're welcome. Thank you for the question.
Okay. So I have another question, and I'm going to answer part of this on behalf of eyecarelive, but for the G2012 virtual check-in, does the patient need to call into the office first, or can you call the patient to check in? How does the patient initiation work for this? I will start by saying with eyecarelive, because the patient is initiating everything, whether it's a message or an actual virtual encounter request, that qualifies as the patient initiation. But John, do you want to answer that for other platforms?
My understanding is that the G2012 can be initiated by the physician as well, but it can only be provided to established patients, right? It's provided in lieu of that office visit. It doesn't have the requirement of being initiated by the patient. But again, having a platform that does it and allowing the patient to reach you through that is always a great thing.
Okay. Are there time frames that are required for E&M telemedicine services?
Well, you're going to be coding at your very lowest levels anyways, so I don't think that you're going to be running up against your time requirement restrictions on doing that. I mean, if you're at a 99201 or a 99212, my guess is that you're going to be about a 5 to 10 minute encounter overall, probably even a little longer, particularly since you have to take a complete case history, go through all of the HPI requirements, medical decision making, all of that. So I think you would be able to fulfill the time requirement for the lower level E&Ms.
Okay, we are going to, let's see, how long will the 1135 waiver last? Do we know?
I don't know.
Okay, we have a couple of hands raised. So first I'm going to take Jason Bolenbaker. Jason, I know you from a past life, but why don't you go ahead and unmute your line and ask away. Jason, are you there? I've unmuted you. See if you can connect with us. Okay, while we wait for Jason, I have another hand raised. Ian, I'm going to allow you to talk if you want to unmute your line.
Yeah, hey, Dr. Papakis, I had a question. Does knowing the patient's orientation as well as their mood and affect count as 2 exam elements?
Great question. It only counts once you get up to 9 physical elements. So, 7 physical elements total. So it would have to be a level 3 visit or higher in order for those to count.
Gotcha. Okay. But if you think that you can do EOMs and potentially have them test their own computation fields, and then you added those 2 on, that potentially is a way to get a 99203 on a new patient, perhaps.
I think, well, I guess technically yes, but I think you'd be pretty stretched to do that and be able to actually get your clinical findings. But technically by the coding rules, yes.
Okay, we're going to go on to some other questions here in the chat. I understand we mentioned that we cannot bill virtual check-in and then in-office E&M code the next day. However, if we build a 99212 on video, but then needed to see them in the office, can the next day be a 99213?
Well, I'll answer it this way. Whatever your initial evaluation management code is, your 99,000 code, is going to be what it is on the day that you provided it based upon what the patient needed and what you accurately provided. Whatever the E&M visit at the next office visit, be it next day or not, is going to also be whatever it is based upon whatever was medically necessary to do and what you performed and recorded.
Okay. Does Medicaid HMO programs, do they pay for telehealth?
Again, Medicaid HMOs are typically commercial carriers that are offering Medicaid-based services. You have to make sure you follow the carrier policies for each and every one of those, and I don't know broad-based across the board. I know many of the Medicaid carriers that I used to do work for and have done work for had some provisions for telehealth, and they generally tend to follow CMS's guidelines. But again, please verify with the individual carrier because I can't make a global statement across the board.
Okay, Richard Hom has a hand raised again. So Richard, did you want to add anything in here?
Yeah, I have a question. The question I had, John, is if a patient was referred by a primary care physician or a triage nurse to an eye care provider, would that, and it's a brand new patient, would that be a brand new patient or would that be an established patient if they got a referral or consult to the optometrist?
It would be a new patient to me so if you had a patient that you sent over to me, the patient would be new to me. So I would have to resort to using the 99,000 code for my telehealth evaluation. I couldn't use any of the actual telehealth codes as they're listed because they require that the patient be established.
Okay, next question. What about, and I don't know if I'm saying this right, orthoptics code 92065?
Not approved for telehealth.
All righty. Next question is, the evaluation needed to be by slit lamp. Have they relaxed this for a period of time?
You cut out, Beth. I'm sorry. Could you say that one more time?
I'm sorry. It says, I thought cornea evaluation needed to be by slit lamp. Have they relaxed this for a period of time?
Corneal evaluation by slit lamp, you mean as far as the codes? The code doesn't specify that. The 92,000 codes do, but not the 99,000 codes. So again, how you want to be able to examine the cornea, and if you feel that you're examining the cornea properly, I think, again, you're going to have difficulties in doing that unless you have, gross things going on. You're obviously not going to see layers of the cornea, but the 99,000 codes don't stipulate by what mechanism. The 92,000 codes do, but not the 99s.
All righty. Quick question here. Is 99423 in Appendix P?
I got to look it up. Hang on. Nine 423.
And while you're answering that, I think the follow-up question to our earlier contact lens question was, if it is a medical contact fit, would you be able to bill for that?
Say one more time. Let me go back to the other question first.
Yeah.
99423 is not in Appendix P, but it should still be billed with the 95 modifier.
All righty. So the follow-up to the contact lens question was, if it is a medical contact fit.
Now, are you talking about a contact lens fit or a follow-up secondary to a contact lens problem?
Teresa, if you're still on, would you raise your hand so I can allow you to elaborate on your question? Let's see, while we're waiting for her, I'm going to take another question from Steve Kirkham. Steve, I'm going to allow you to talk if you want to unmute your line.
Okay, I have a question. If the documentation and platforms requirements have been relaxed, then through the platform that we're being presented with here, I understand that certain things happen automatically, but if we're doing an E&M visit and we're doing it synchronously, then do we have to somehow file away some video record of the whole thing? And how do we put that in the medical record, or do we attest to it? And the same thing would be with regard to the amount of time that we're spending. Do we have to video the entire time sessions every time throughout the week and then compile them somehow? Or do we just attest to these things that we use this technology?
So again, remember, your medical record keeping hasn't been relaxed at all. What has been relaxed, let me maybe summarize it this way. What has changed as far as relaxation? HIPAA requirements and enforcement, allowing common devices such as Skype or FaceTime. And the biggest one was allowing the patient not to have to be at a specific location or in a Medicare shortage area or a provider shortage area, and allowing the patient to be able to initiate the service from home. Those are the three things, the big three things that have changed, okay? The medical record is still, you have to have your start time, your stop time. You have to keep all of those types of, things. All of your 99,000 code requirements are still the same as well.
Makes perfect sense. Most onerously for us would be somehow videoing the entire sessions and then attaching them to the medical records and pulling them off of iPhone.
No, this is not a stored video. This is two-way video communication.
And then documenting that you use that is what they're looking for, and documenting the amount of time that's been spent?
Yeah, so the video is just happening contemporaneously in parallel, right? That's how you're doing your physical examination of the patient, is via video.
Okay, we don't have to I don't know the platform. That platform is not recording the entire video session to prove that you spent a certain amount of time on it, or we're just making
No,
that statement in the medical record, right?
Well, it logs your start time and your stop time. So if you're not using a platform, you're going to have to manually make a note of that in your EHR. Started at 8:03, stopped at 8:17.
Got it. Okay. Thank you so much.
Yeah, my pleasure.
Thank you, Stephen. Okay, moving on. Can you bill for time if you're doing a rehab exam like low vision? Can you use the tome component?
So I've given you guys the code sets that are allowed via telehealth. When we start to get into other code sets of what we're doing, those are generally not qualifying for telehealth encounters. So remember, telehealth is to be able to provide, it's not to replace your clinical practice, it's allow you to address, your emergent needs of your I shouldn't say emergent needs, but needs of your patients who need to be seen.
Okay.
It's not to provide a contact lens fit. It's not to provide, different types of, telescopic evaluations or low vision exams and things like that. It's based on what you can do via a two-way video that are allowed, that where you can capture an adequate case history, you can capture what's going on with the patient and then get them moving on their way.
Alrighty, so I think we touched on this, but maybe there were different code sets. So patient seen in the office 2 days ago with a 99213, and then they're followed up 2 days via telehealth and billed 99212. Is this okay?
Yes, that would be fine.
Okay.
Because you don't have the requirements with the 99,000 codes.
Okay. Now the next question is, if we haven't established a written protocol for consent yet, can we still get a verbal consent to treat if there's an emergency?
You don't need written consent. You just need verbal consent. And the verbal consent needs to be recorded at least once a year, and it should be done prior to any services being provided. I would actually tell you to do it each and every encounter, just to write it down that you had the patient's verbal consent.
Okay, would the cumulative time apply to just the physician time only, or would it include any communication with technical staff?
It's just the patient-physician encounter.
All right. If we waive the deductible for the patient, will Medicare pay for the exam during this time frame?
They just paid the Medicare allowed amount, as I've showed you on the screen, based upon your geographic area, recognizing that I'm using national averages, not your specific amount.
Sure. Why would you code an e-visit versus telehealth visit?
I don't understand the question. I'm sorry.
And I can't, it's someone anonymously wrote that in. So if that was you, raise your hand and we'll try and get you a more extensive answer. Moving on, does noting the patient's orientation, mood, affect count as two exam elements?
Yeah, again, I answered that question just a little bit earlier, and that only, remember that mood and affect only applies when you get to a higher level E&M code, not to the lower level ones that we're going to be doing.
Okay. How is a G2012 different from a 99441? Medicare covers the G code, but not the telephone services. Could you explain the difference, please?
Yeah, this is generally a video conversation, right? Whereas a telephone service is by telephone, okay? So you were checking in with that patient, right? I mean, that's basically the difference.
Okay. So here's a question for you, Dr. Rampakis. Would you be able to give an example of how the codes, I think there's a little bit of a typo here, something about how the codes of visit and what qualifies as patient initiated? Can you call back the patient through Skype or FaceTime and bill that through E&M codes 990? I don't know if that quite makes sense.
Yeah.
Can you give an example of how you would code a visit and what qualifies as patient initiated, I guess is the question.
It's where the patient initiates the communication, right? The patient has to contact you. You as the practitioner can't originate the encounter. The patient has to originate the encounter.
Alrighty. Let's see. Can you go over some case examples for codes? Yeah.
Probably not, because I don't want them to be misinterpreted, because when we start getting into clinical cases, there's so much variation on how everybody does that. I'm happy to answer, we should finish up here in just a second, but, to talk about basic telehealth services, which we've covered, and what is allowed during those visits and how we use those, it's fine, but it's really difficult to get into a clinical case.
All right. 95 modifier with the E&M codes.
Yes.
All righty. Let's see. Why is the 95 modifier necessary when using online eval codes 99421, 99423?
Just to specify that it's being provided when you're doing two-way video communication, and also your place of service code is telling them that you're doing telehealth.
Okay. You briefly discussed that time cannot be used to bill these exams. Is that because it is actually not allowed, or because the assumption is that these telemedicine visits are assumed to be short? In other words, what if it is a long discussion? Can time then be used?
So again, the time question that came up earlier was specifically with respect to using time as a determinant for a 99,000 evaluation and management code. I did not make a blanket statement about time with respect to every other code, because as you can clearly see on the screen with the online digital evaluations, time is very important. Cumulative time is very important, right, in those. And in our other codes that we're using, then time also has a component as well.
Okay, can you bill an anterior photo with the telehealth codes or E&M codes?
You cannot.
Okay. CMS says telephone call works with G2012.
Okay, I would have to double check that reference. If somebody could send that to me, that would be fine.
All right. Following up to you saying that
Beth,
it is...
last question, okay?
Okay, all right, let's see. Wow, we have a lot. We have 53 open questions.
Yes.
Here's what I'm going to say too at the end, guys. If these questions, if you still have these questions, John, where would you like them to route their questions for you?
To you.
Okay. Here's what I'm going to say, that we're really inundated with sales calls right now. So I will try, do your best. If you send us an email at sales@eyecarelive.com, we will try our best to reroute those to John. We are running on very little sleep these days, and be gracious with us. We will get to you ASAP, I promise. Let's see. Let me find a good one to end on. Let's see. Okay, here's one. For 9942X codes, what if we communicate with the patient on day 5 and then decide we need to see them in the office the next day, day 6? How do we bill this visit? 99 blank and not 9942, or bill both?
So again, it's whenever your first communication starts, that's your beginning of your 7-day period. Okay? So you're not going to be billing any code if that leads to a visit within 24 hours after your 7-day period ends.
Okay. One last question, because it's a continuation. They wanted to know what you were going to say about text messaging. When I said tech and you
text messaging is not a covered service.
Okay. All right. Well, it looks like we've reached our time. We have a ton of questions here. I'm going to see if there's a way that I can download these somehow. It doesn't look, I'm looking right now, it doesn't look like I can. So if you want to send, if you have John's email personally, feel free. If you don't, email us at sales@eyecarelive.com. We will try and forward as many of those to John as we can. Thank you all for attending. If you have questions specifically about the eyecarelive platform, please also contact us at sales@eyecarelive.com. Thank you all for joining us. We will send out a recording of this webinar once it completes tonight. It takes some time to download, and we'll be sending that out afterwards. So thank you for joining us. We appreciate all of your insight.